During the ocular surgeries, in order to immobilize the eye muscles, a retrobulbar block is given, which is more efficient than the peribulbar block as it is deeper and uses less volume than the peribulbar block. Retrobulbar block is more efficient in producing anesthesia and akinesia, that is, absence of muscle movements, and it has faster onset of action. When it comes to safety, peribulbar block is given as the retrobulbar block carries a higher risk of serious complications such as globe perforation, retrobulbar hemorrhage, and injection of the anesthetic into the cerebrospinal fluid. Depending on the type of anesthetic that is used, a block may last over 4 hours with a mixture of lidocaine 1% and bupivacaine 0.3%. Retrobulbar block can be used successfully for corneal transplantation but may require a supplemental facial nerve block as it does not block the facial nerve. A retrobulbar block can block levator palpebrae muscle but not orbicularis oculi, which is supplied by 7th facial nerve. The local anesthetic is injected into the retrobulbar space, the area which is located behind the globe. The position of the patient while giving a retrobulbar block should be supine and in a straight looking gaze. When injected into the muscle cone, the main aim is to block ciliary nerve and ciliary ganglion with cranial nerves 3, 4, and 6. This regional anesthesia is used in intraocular surgeries involving lens, cornea, and anterior chamber of eye, especially in the cataract surgeries and other surgeries like strabismus surgery, enucleation and evisceration, cyclodestructive surgery. The two pop sounds which are heard while giving the retrobulbar block are the first pop sound being the orbital septum and second pop sound being the muscle cone. Within these two cones, the anesthetic is given. The needle that is commonly used is 22 gauge 35 long needle, which is inserted at the junction of lateral 1/3 and medial 2/3 of inferior orbital margin. The needle is first directed straight, backwards, then slightly upwards and inwards towards the apex of the orbit up to a depth of 2.5 to 3 centimeters. The superior oblique muscle is not usually paralyzed as the fourth cranial nerve is outside the muscle cone. The common complications that arise during the procedure are retrobulbar hemorrhage, ocular perforation, subarachnoid or intradural injection, diplopia secondary to myotoxicity, cardiorespiratory distress, contusion and atrophy of the optic nerve, vascular retinal occlusion, and seizures. The local complications being the hematoma, optic nerve damage, perforation, which can lead to blindness, and the systemic complications like brainstem anesthesia, oculocardiac reflex.